I want to thank you for being here today. This is the first module of a series of modules titled The Life Cycle of the Healthcare Dollar. And when you look at the financial management in healthcare, I think it needs to start with knowing how the money flows through the system, whose hands it's flowing through, and that when that's understood, other aspects of the revenue operations workflow that supports the running of your medical practice will then make sense. So to get started, we have in this scenario an employee who's employed by an employer. The collective dollars that are generated there from medical premiums then given to a health plan like Cigna or United or somebody, and then they use that money from the employee and the employer to then manage those healthcare dollars to then pay the nurse practitioner or the physician. So what's that really look like in dollars? Scenario here from August in 2015, actually true benefit plan. We had a $5,000 deductible coverage. $348.55 was the cost for that employee-only premium. The family coverage, $1,000 on the $5,000 deductible plan, and you can see here the $1,436 a month for a $1,000 deductible plan. So you're talking about, for an employee-only coverage of about $5,700 a year. And on a family, you're looking at $17,000 spent for that one family. Now, let's take a look at, well, what's the numbers we're really talking about? You're talking about 18% of the gross national product spent on healthcare. You're talking about $2.2 trillion in 2006, which has now moved up to $3.8 trillion of money hanging out there that were spent on healthcare. And by 2022 ahead of us, that can be up to $5 trillion. There's a lot of money on the table that we have access to as healthcare providers to get paid for the work and the training you're learning of what you're doing. That's kind of exciting. As well, when you look at it and say, well, how much money are people spending? Ford spends $1,500 for every vehicle, and Starbucks actually spends more money in healthcare than they do on coffee. And that's their core product. So let's bring that back, though. We're talking about trillions and billions, and I can't really understand that. So let's go back to our 348.55. How does that get collected? Well, we know that unless your employer is paying 100% of your medical premium, which is a pretty cool deal, the employee's got to pay up a portion. In the scenario here, 75% is being paid by the employer, which is $261.44. The employee gets $87.14 taken out of their paychecks. Now, that's a monthly figure, and of course, we know money comes out on a paycheck, 52-week cycle type thing, but at the end of the day, we're talking about $87.14 a month that you're paying for healthcare in that trillion-dollar scenarios. $261 is coming from the employer. Well, what happens to that money once the employer collects it? They give it to a health plan. What's the health plan do with it? Well, I've worked for the health plan, and we sat down and we had to create a budget and said, well, how are we going to spend this money? Well, like any good business, you got to create a budget and figure out where you're going to spend the money. Out of my 348, I'm going to say 32% is going to go to pay hospital claims. 39% is going to go to pay doctor's claims. I'll stick 14% to pay ancillary PT, OT, my behavioral health carve-out company. 15% is going to go into my budget. So I've just taken that premium dollar and I've allocated it into those buckets of where I'm going to spend money. So let's take another scenario and take a look at this. Where are my buckets? I got 4 buckets. When you sit down and you start hearing about and thinking about, what do I hear about all the time? I hear about, we're going to pay for outcomes. We're going to pay for quality. We're going to economically profile this nurse practitioner against that nurse practitioner, or physician against physician, because if that physician's providing healthcare better, faster, quicker, and cheaper than another provider, I don't want them in my system because it's all about keeping money in the bucket. If I keep money in the bucket and I don't empty the bucket, I'm doing well. So all those incentives, all the payment plans are all centered around keeping money in the bucket. But what's exciting about it is they've realized the value. A hospital, we spend $17 billion out of that hospital bucket to fund readmissions. Why are we readmitting people? So Medicare came out and said, hey, let's put $600 million in that physician bucket. It's going to save us $17 billion on the hospital bucket, so I'm shifting the budget around. Where am I going to spend my money? So if I can pay a nurse practitioner to manage the 30 days post-discharge of a patient with hypertension and diabetes, lipid management, out of a hospital, and they can keep that patient out of the hospital, they're going to help save me $17 billion, and in turn, I'm going to pay that nurse practitioner $600 million. Obviously the group, but you get my point. So what's happened now is these new financial programs have come in place that, oh my gosh, this is a perfect program for a nurse practitioner. Now, it's designed around paying the primary care physician work they always complained about, that I always take care of my patients after they discharge from the hospital. No one ever pays me. Well, they've come up with a program that finally pays you, but do you see the physicians running across the street to do it? No. And let me tell you why. Their practice management team, the people responsible for the financial management of those healthcare dollars in that practice, are not current on what's going on. Their head is so far down in the ground looking and just taking care of patients. I'm so busy taking care of patients. I don't have time to take care of these other things. You're missing out on opportunities. This is why you've got to have another element of what this program is about, making sure your practice is running right. Because here's a huge opportunity, and we see nurse practitioners grabbing at this one quite a bit. There's money there to pay us to do the work we do and provide the service we want to provide. But you've got to understand the economics of how that works. So when you look at that, you're going to say, well, clearly my customer has to be the health plan because they've just moved $600 million into the bucket to pay me. That's not their money. That money's coming from the employer. That $348.55 went to the health plan. The health plan has the fiduciary responsibility to manage those buckets and where money moves around to make sure that spending is controlled and we make money and the providers get paid. Let's look at a scenario, in case you disagree with me. I have a factory down the street that 60% of the patients that come to my practice, they love me, they praise me, they can't expect or want to see any other healthcare provider. All of a sudden, United comes in and says, hey, I'm increasing your rates 20%. The factory and the union go, yeah, we're not doing that. We're moving to Aetna. Terminate United. All of a sudden, you don't have a contract with Aetna. Nobody in your practice is paying attention because we're so busy taking care of patients. We don't have time to look up. And all of a sudden, 60% of your business just walked out the door. Or worse, you have a contract with Aetna that pays you horribly, and you're sitting around the table going, why am I not making as much money as I made last 2 months? Well, because that business just shifted from $1.25 for a service down to 95 cents for a service, and you're going, hey, I'm making less money, but I'm working just as hard. What happened? My billing people aren't working right. No, that employer at that factory just shifted their business to another plan that you're either not on or pays you less than you were on. So why are you reacting? You shouldn't be reacting, because if 60% of my business was coming from a single source, trust me, I would know exactly what they're doing and what's going on with them. But do physician practices know this? No. Their focus is saying, oh, well, United Healthcare, that's where I see most of my business. I got to work with United. That's not where you work. You got to take it a level deeper down to the employer and know, hey, I need to be with that benefits administrator. I need to know the union rep, and I need to know the broker to know that if that factory is going to shift to Aetna, I want to be at the table. What leverage do you have? You see 60% of those patients that's coming from that factory. You can tell the broker, hey, you're switching to Aetna. I don't have a contract with Aetna, but hey, in that deal, for you to shift that business, can you maybe make a comment that says, Aetna, you need to contract with this nurse practitioner program down the street because that's important to us. Of course, Aetna is going to reach out to you. Now, all of a sudden, when Aetna is reaching out to you, who has the leverage of what you're going to get paid? You do. They got a huge book of business waiting on the fact that they need to get you in network. All of a sudden, there you have leverage. So, yes, United's the one paying you. They're not your customer. Your customer is the purchaser of the insurance, the employer, where the money lands. Because here in this scenario, that employer just shifted things. They either messed you up, you don't know what happened because you're making less money next month than you did this month and you're not sure why. Both of those are reactive. And again, we don't want to react. We want to be proactive. So let's take a look at the learning objectives for the first learning objective of this module, which is review the customer being the purchaser of insurance. We've learned how the buckets of money exist and how we can shift money around the buckets, but we know that when we get that $300 and some dollar premium coming in, we know these buckets exist. Let's stop for a minute and take a look at behavioral health. Behavioral health isn't paid out of the physician bucket, it's paid out of the ancillary bucket. It may have a completely different arrangement and deal. You've got to understand where the money's coming from to understand who you should be talking to. We all know behavioral health is not paid out of the medical premium dollar bucket. But knowing which bucket is what makes it important. We also know that there's special programs that go in place to say, hey, transitional care management, I'll put $600 million in your bucket. Here's a new program, go at it. We have programs built around transitional care to support nurse practitioners in practice generating money on a brand new program that was released by CMS. You got to stay current on these things, and this is the kind of information that's important in running your practice. So we'll stop here. We got two more sections of this module, but I wanted to keep these videos a little bit shorter grouping so that we don't have to have a 3-hour video. Thank you.